Can everybody see the screen?
Yeah.
Okay. So today I'm gonna present about the impact of pairing on therapeutic rapport and treatment outcomes for children with autism. So I came up with this thing because nowadays I'm going to school to do the uh, school intervention, and what I find is that um, teachers and students are kind of in a battle. Like students feel that they're not getting enough help, and then parents feel that way also, and then they ask for the school to cooperate with them, but it's sometimes burdensome for them to do that. And so what I find is like it's kind of going in a vicious cycle where they don't want to help each other. So I thought, like, if we could come up with something that could show that actually pairing is the most important step to get through getting better implementation on things, we would have to show like the evidence and like how we can do it also at the center. We haven't really showed like BSTs on how to do pairing. Well, I personally haven't, so I I got interested in this topic. I'll just present what they did. It was in 2019, maybe a bit outdated, but it still gave me some good information. So this study began where they said pairing is positively related to therapeutic rapport and therapeutic outcomes. However, there hasn't been many studies that have actually evaluated the skills necessary to pair effectively. So when people asked newly trained RBTs about what they learned for to be an RBT, they learned many skills such as like verbal operands and things, but they didn't really get any much help that they need that to know how to pair. So the purpose of this study was to conduct pairing skills training, and after some new technicians get the skills training, they get assessed for the effects of this training on behavioral indices of therapeutic rapport and child treatment outcomes. So the study was designed using concurrent multiple probe design, and they had five instructor therapists and five kids also. So there were two studies going on. So first, for the training, they got training based on BSD for 6 pairing skills with an adult confederate. And following that training, if they passed above 80%, they used this skill and then had time to pair with the kids at every session. So this protocol used for 4 children diagnosed with autism who didn't get much DTT training before. And during the first 20 minutes of each therapy session, they had the pairing session. And the result of the study was therapists could efficiently achieve the competency level when they had the pairing BST. But they needed some feedback when they were actually doing the pairing session with the kids. So, and some of the behavior technicians, they lost the skills from time to time. So that's where they needed to rebuild the skill with the help of the supervisor. And when implemented, pairing was related to increased physical approach during free time and at the teaching table, as as well as there was less interfering behavior during the sessions. So the results um, looked at these kind of behaviors and then thought this was the result, or this was the behavior, the consequence that showed that the pairing worked, like the physical approach and the uh, lessening of behavior, problem behaviors during session. And there was one more thing that from the result was that the accuracy of academic responding from baseline to intervention, it didn't show much difference, and it was the study wasn't very sure if it was due to the pairing that was done before or other things that interfered to make this accurate academic responding to work. So going to the introduction for the therapeutic rapport, um, they researched some of the researches that was done before for the therapeutic rapport. And like I've mentioned before, LeBlanc, Taylor, and Marches surveyed certified ABA professionals regarding the need for further training on developing therapeutic relationships. And out of 221 people, 82% said they did not receive formal training in relationship building skills, but felt it was very necessary. And of course, I also felt like this. And when I was training my therapist also, I don't think they had very much chance to actually really learn like other skills for this to happen in the real center therapy setting. So this when I was reading this, I was really agreeing with this part. And then they also reported that their training did not adequately prepare them to handle difficult therapeutic relationships. So for like when children didn't have much interest in tangibles or toys, if they had a very limited interest, it would have been harder for them, but they didn't get enough training in that. So, and when a therapist and therapeutic setting are continuously associated with challenging tasks, it's obvious that they will become conditioned as aversive stimuli or reflexive conditioned motivating operations. So when they see the therapist, instead of actually associating them with good things, it's like, oh, they're going to make me study. They're going to make me sit in the chair. So it's like they're conditioning us with the aversive stimuli. And pairing includes strategies such as reducing task demands, providing high rates of non-contingent reinforcement, increasing choice, increasing task novelty, and using errorless teaching. This was some of the findings, some of the things that the early studies said that is needed for pairing. But in this research, they didn't use this one, but some other strategy. So I'll explain them later. And in order to be effective in clinical setting, researchers have suggested that pairing must be gradually faded with increasing task demands. So this is also something that is really obvious to us, but has been studied by these people. So at first, we need to pair much more time, and then as they get used to us, as they are paired with us and have rapport with us, we can't spend as much time doing just pairing. So we need to gradually fade that and then turn into the task demand. But it doesn't mean that we stop pairing all of a sudden. The pairing has to go on, but it's just having the balance. So the task demands should be increased and the pairing job needs to be decreased or given in a non-contingent form. And for the training therapists on pairing skills, so initially described by Parsons and colleagues, behavior skills training is an evidence-based teaching procedure and considered the gold standard for staff training in ABA. So I think BSDs, everyone here attending would know what it is. So it just consists of 4 steps, instruction of what the skill is. Actually, first they kind of explain what the objective is of this BSD, and then they give the instruction using task analysis, and then they model themselves, and then the therapist does the rehearsal, and then the supervisor gives some feedback, and it's like an ongoing process of doing this. And so here they use the method of picking the therapists. So the therapists were mostly, actually everyone was master students, ages 22 to 24 years old, and were recruited as instructor therapists. So they had to have competence in conducting DTT sessions, so minimum score of 80% from their evaluation form, but they didn't have much skill in pairing. So their pairing scores scored less than 50% on 3 out of 6 skills on the pairing skills competency checklist. It's on the appendix. So if they met these 2 criteria, they were picked, and then there were 5 students, master students, who were picked as therapists. And for the children, there were 4 children who were recruited from the waitlists of local ABA service organizations. And children were eligible for this study if they had written documentation on autism diagnosis, and if they hadn't had active ABA-based intervention before, and 3, if they did not engage in severe challenging behaviors such as self-injurious behavior or aggression. But one child withdrew from the study, so altogether they were a set, so one therapist had to withdraw from this study also. The experimental design, as I explained before, it's a concurrent multiple probe design across therapeutic diets, and then followed by the second replication. The independent variable were, the first one was for the behavior skills training for the therapists, and the second was for the pairing intervention for children. So pairing here involves following the 6 skills adopted from Lugo et al. So proximity, and then acknowledging vocalization. So when proximity means that like sitting where, being in close distance with the children, and then acknowledging vocalization is something like reflecting what they're doing and things like that. Like, and then imitation of play, behavior specific praise, and initiation and creativity. And then the dependent variables were, for the therapists, it's the pairing skill performance after the BSD. And then for the children, it's the latency to approach the therapist when the therapist called the children's name, during the free time, and during and at the teaching table. And then there was also for interfering behaviors, like checking if the interfering behaviors happened more often or less often, and how accurate the academic responding was after pairing. And then the results here, the first one on the left side, it's the percentage of pairing skills demonstrated by each therapist. So before on the on the left side where there's baseline, they didn't have much skill, because when they were chosen, they shouldn't have had any much skill than 20%, I guess. And then when they got the BST training, they reached percentage above 80 within 5 CSD sessions. And then if you see figure 2, the frequency of pairing skills demonstrated to master criteria for each therapist is shown. So on the baseline, they showed zero, some showed zero frequency of skills at mastery for the 6 categories that I told you before, like approaching and then imitating, the proximity, those things. They had 0, or 1 had 2. And then later on, within 5 sessions, they all reached to 6 skills at mastery level. Yeah, so this is the result for the first study for the therapists. So proximity and acknowledgement of vocalizations were performed with the highest degree of integrity across all therapists. So these were maybe the easiest ones for the therapist to do. But for the imitation, it was performed with the lowest integrity across child therapist INs. So imitation was a bit harder, I guess. But overall, pairing was moderately effective at increasing. These are the children's names, I guess. Maya and Carl's approach behavior, and highly effective at increasing Mark and Joey's approach behavior. So out of 5, only 4 could participate. So there's only result for the 4 kids. So the approaching behavior was moderately effective to highly effective. And then for the latency for all children to sit down at the table, it decreased at moderately effective level. And overall, the interfering behaviors all reduced at a highly effective level. So for all children, so this was very effective. I think this was the most effective outcome of the pairing, that they didn't show interfering behaviors. So figure 3 is the latency in minutes between the start of break and the child physically approaching the therapist. So though they said it's like mildly effective and highly effective for some kids, there's a bit of variability in this graph I see. So, but you can make your own interpretation also. A data point at 5 minutes indicates that the child did not spontaneously sit down during the probe. So anything that goes higher than 5 minutes, they just ask them to sit down. So the most effective was for Mark, Mark. And then at figure 5, it shows the rate of interfering behavior exhibited by each child participant during the sessions. So as you can see, the y-axis is rate of challenging behavior, frequency per minute. So you can see for all the 4 kids, it kind of decreased for all of them, and then remains in the low level even through generalization, and then after 1 month follow-up also. Figure 6 is the percentage of accurate responses during discrete trial teaching. And then, so this shows some children learning. They see, the study sees it as a limitation because it might not be because of pairing, but just them getting used to the DTT and other things might interfere. So they need to control more things in the next studies. So in the discussion, consistent with previous research, all therapists achieved their overall master criterion with 5 sessions. However, feedback was required to maintain high levels of performance with child clients. And I think it's it's normal. We need feedback. Some skills we fall back on our skills. We need to renew them. We need to always get feedback and then reach higher standard. So I think this is normal to get feedback and to maintain high levels of performance. And although a continuous schedule of performance feedback is likely required when pairing sessions begin, feedback should be and may eventually be thinned as competency is achieved with particular clients. So I think this part they're talking about, like they should also be, the therapists also should get more independent in performing by themselves also. So not just always relying or be dependent on the feedback, but so the feedback should be thinned also eventually. And a relatively smaller effect size was also observed and approached compared to previous studies. And these results may be explained by procedural differences. So the earlier studies had conditions where they either engaged in pairing or delivered task demands. So, but in this study, they did both. They did pairing first for the first 20 minutes, and then they moved on to task demands. So it might be the difference in that. And secondly, children in Schillingsberg et al. Were given the entire 20 minutes to approach the therapist, whereas children in this study were only given 1 minute before being prompted to sit and complete DTT trials. So this was also a big difference because 20 minutes and 1 minute is really a big difference in time. And finally, DTT began as soon as the child was at the teaching table, which might have conditioned the table as a CMOR. That didn't happen in the other studies because other studies, it had like the whole pairing session all together and then the whole task demands. But this was turning from pairing to task demands. So obviously the teaching table might have been conditioned as something aversive. And during generalization across settings, all children maintained constant levels of approach during free time and when at the teaching table, similar to intervention. And consistent levels of approach suggest that the therapist or another extraneous variable might have been the discriminative stimulus or setting event for approach. So during the generalization, the children and the therapist randomly swapped. But even during that time, the consistent level of approach was there. So they're suggesting that the therapist or other variable might have been the SD for SD for the approach. And when assessing generalization across the therapist, child participants demonstrated mixed results, indicating that further research in this area is needed. Yeah. And for the interfering behavior, it decreased immediately upon the introduction of pairing for all children. So like shown in the result before, this was the most effective result that showed. And further, all children except for Mark demonstrated increased level of interfering behavior when paired with a new therapist. So when the therapist changed, they showed more interfering behavior. So interfering behavior did not increase across settings. It's when the therapist changed. So this pattern suggests that pairing and strengthened rapport affected the level of interfering behavior exhibited by each child, rather than the habituation to the teaching environment. So they're seeing it as that the pairing between the therapist and the child was actually the component that affected this behavior to increase. And when matched with a pairing therapist, the percentage of accurate responses demonstrated by child participants continued to progress at a moderate and variable rate. But the lack of successful trials when DTT was conducted by a different therapist suggests that academic responding was positively affected by the paired therapist. So they are seeing that it kind of also affected the successful trials with the children when the therapist changed from the paired therapist to the new therapist. But we'll show you the limitation. The limitation is that there were differences in the delivery of performance feedback between the first and second sets of diet. So when the therapist changed, the first two therapists to complete BSD received feedback when performance decreased. So they didn't receive continuous feedback, but only when the supervisors saw that their performance were decreasing, they received the feedback. While for the second two therapists, they received continuous feedback throughout the intervention phase. And simplifying the criteria may be just as effective at improving rapport in the current study, while enhancing treatment fidelity and reducing the therapist's response effort. So they saw that having too much of the criteria to meet for the therapist while they were doing the BSTs, they thought it was kind of too much for them. So even though they simplify the criteria a bit more to reduce it to a lesser stressful situation, it might have been better also because it's reducing the therapist's response effort when they also have to do the session and think about other things. Like focusing on the pairing just itself might be too much for them. And because a functional assessment wasn't done before, interpretations of interferent behavior should also be taken cautiously. And there were two potential threats to the internal validity of academic responding. Like I just said before, there might be other things like historical events and participants just growing older, like participant maturation. So they might just be learning by themselves while they are getting older. And evidence to support the use of approach behavior as a reliable indicator of the therapeutic rapport remains limited. So they saw like pairing as approach behavior as a product of pairing, but they don't have supportive evidence to see that the approach behavior is a consequence of pairing. So it has to be studied a bit more. And this is the link to where I got the paper. And that's it. So if we could discuss a bit about this, or because for this to be a CEU, I know that it has to be applied to our clients, to our actual clients, and then yeah. So if you have,
You mean the discussion has to be more practice-based?
yeah, I think because yeah, as far as I know, we have to like digest this and then apply it to our clients also. So yeah, that's how I know it. Mm-hmm.
That was great. Thank you. That was really good research.
Did you understand what I was saying, or was I
the
doing
studies were
on my
clear
own?
and the diagrams were clear also, the graphs, I mean. The first study, the protocol they used for like the BSc training, we've actually been using something very similar at the center I work with.
Mm-hmm.
I think we have something we call the child-led play protocol, and we use it with therapists as well as with parents. So we train parents using it, and we do 5 minute long sessions with parents, and we use a BST model to get them to play with the child and not give demands and instructions. We never really talked about it in terms of pairing, but it is like functionally pairing, yeah. So it's brilliant. It
Mm-hmm.
works for therapists and for parents, caregivers alike.
Yeah, we're creating also like a BST, like a document to, sorry, one second. We're at STEP, we're also creating like BST documents for pairing. So I think like the BST model I think it's an effective, and a lot of the therapists quite enjoy going through the BST model. Um, I think though, like when we train therapists or parents, support worker, it's more of the buy-in to implement those. So I think like as part of the first step in our BST, where it says the part where we do the discussion, I think it's important for the stakeholders to understand why we're teaching pairing, what's the function, what's the benefit. So I think a lot of the buy-in has to be in the discussion when we give an understanding of what it is. And again, it goes back to like we need to use lay people language to understand that. So if I explain like pairing in
Yeah.
in technical terms, they don't get it. They like, why should I do that? But then when I use more daily language, like pairing is trust. Imagine if you are someone who has a teacher and you don't trust the teacher, how can you build a relationship? So when it's sort of like the language also that goes into that. And again, like, and then again, like those protocols, what do we do? What are the behaviors that we engage in pairing? Like, as Amna says, like, you don't ask questions when you play, just make comments. Look for indicators. So I think like the approach is a good indicator, but there's also other indicators such as eye contact, because eye contact is the hardest for especially kids on the spectrum. But when they do have eye contact with you, they maintain that, or just a glance or something like that, a smile. I think that also are indicators of successful rapport building. So it's not always an approach, and and what's hard as well that I find with new therapists is that they're very um, result oriented in sense like we have like target trials per hour. So what they see as um, productivity is trials in DTTs. So they forget about how important the pairing is. And they don't recognize pairing as an opportunity. As like Jiun has said, like pairing is continuous. It's not just a one-shot thing. Because like, I mean, look at us. When we build a relationship, we still have to maintain it, right? Throughout the years. So it's the same thing with our kids that, in each session, we still have to maintain it. And some therapists don't understand or can't identify the opportunity, like breaks are good opportunities to build rapport, right? Or when you first beginning a session, you do your reinforcer assessment. Those are good opportunities to build rapport. Joint attention, if it's in the program, that's another opportunity for building rapport. So I think like I find like I have to structure it in for them until they get used to, like, oh yeah, we did this in during our break, so I'll generalize that with other clients. So I think like the BST is quite important also to indicate in there what are opportunities in session to continue with rapport building. And I think that's a lot of it's missed, I think. Yeah. at least from my experience, from my side.
Yeah, thanks. Oh, Tanya, do you have things to say also?
Oh, I just wanted to say I really enjoyed your presentation, GN. I think pairing has been a really big discussion at my center also, because we've been getting, because we're a new center, so we're getting like really green therapists. They're all very new. A lot of them might not have, they have like very limited experience working with kids. So they're not as like I don't know a better word, like friendly or
Playful.
like very robotic sort of, which is very very hard for me. So we spend a lot of time using BST to teach pairing in their intake training process, so like the first month. And I think today you presented really good information. Specifically, I'll be reading those papers that are cited in the paper you presented about like the different, like the 6-step pairing. Because right now, when I do training, I don't know about you guys, maybe you can give me some advice also. I try to make it as simple as possible because I'm scared to like overwhelm my therapist. So yes, pairing consists of so many things, right? Like reflection and all the other stuff. But I don't know, I feel like if I train all of that in the beginning, they'll be stressed. I don't know, do you guys have any experience perhaps that you can share for the initial like therapist training when they first like joined the center? Do you guys think it's more effective if we give them like that detailed of training, or just like a general overview? Okay, pairing is essentially where you build trust with the kid, and what you're doing is you're not placing any demands, you're like the giver of all good things, and then we do a little bit of role play. And then later on, I find that as they get more comfortable in their role, that's when I really go specific into like, okay, how do you like echo and how do you imitate their play behavior, things like that. Yeah, I don't know, how have you guys been training your therapist so with this pairing, because it's like a big, sounds simple but not really.
Mm-mm-mm.
Yeah,
And
we've found the same. Sorry.
yeah, go on, Amna, go on.
I was going to say we've had the same issue at the center I work with. When new staff start, um, a lot of, because it is down to the person's personality at the end of the day. Some people are very creative, they're just fun, they love being around kids. Some people are not, like, they don't have that kind of personality and they feel very reserved. And even for me, it can be very difficult to sometimes, and it also depends on the client. This is another thing I wanted to mention, that with some children who are like on the lower end of the spectrum, pairing can be even more challenging than the children who have more skills or like more engaged. Like children who are more vocal, have more eye contact, more play skills, like I said. And the other thing with the new staff is, like you said, Tanya, that when they start, it is a lot, it's quite overwhelming, but also they feel like they're put in the spot and that they have everyone's eyes on them. It's very stressful. I remember being a new therapist years ago, and I remember being watched, and I had my supervisor there and the other RBT who was training me in the session with me. And you can't really feel like, you can't be natural and just playful with the child like you would if you were on your own. It feels very awkward. And yeah, so maybe waiting and gradually implementing the BST. And I don't really have any advice, but I acknowledge the problem and the difficulty there. I've been there, so I can relate. I know what you mean.
You can do it two ways, actually. Well, like not two ways, but like, when you do your hiring. So what we do with our hiring is that we have interviews, and then we do like a behavior-based interview, but we also do like we invite them for a second or third, if it was it the second or third process, it's where we put them with children, and then we see how they play. All we just said is just play with the kids, that's all, nothing else. So when I
I love
think,
that. That's such a good
yeah,
idea.
I think like with building rapport is very tied into play, especially with kids, because that's their world. We have to be able to go into their world, and that's the thing that they enjoy most, you know. So when you see therapists making effort, you know, look, it's not always successful, but you have that, you know, it's not giving up, and then you have those that have a good connection. You get to see and make your own judgment. So from there, like I think like if you can afford that, that's a good way to kind of like ease your job a bit with training. A little bit discriminative, um but in terms of the but in terms of the BST, I think what look at do like a component assessment analysis. So let's say, like you said, Tanya, you're on the right spot where you said that it's okay. When we look at rapport building, there's components to that. There's this section, this section. So break that down and then see, they may not always come as what is the priority, but then you can kind of arrange it. Okay, what do I teach first in, you know, in rapport building? You could do like, it just depends. Like you could do like a week spread out in sessions or out of session. If you have team day, you can teach that during team day. I remember that one of our team days, the director had an activity where therapist was assigned toys, and they had to use those toys to interact with the kids. And the toys are like just regular, like just objects. Sometimes they're not related. So then you have to think out of the box. It does put you out in, it does, you can tell like in the training who makes that effort to try to be creative. Look, I think the trying part is very important. You know, they may be rusty, but if they have the motivation, I think that makes it easier. And it may take a while for them to come out of the shell. And I think like, I don't know what it is. Like, I feel like with the therapists that we have, the younger generation therapists, they feel embarrassed to play and make a fool out of themselves. And so I think it's also like, you know, getting them out of that shell and, you know, just have fun. You know? It's less stressful. It's therapeutic for us too, you know. So yeah, I think that's all I like that comes out of my head. Hope that helps.
For me,
Yeah, that's
yeah,
advice.
yeah. For me, I agree with Tanti also for the out of session part, like make therapists think of like new ideas and stuff. But for them, for the pairing part, I think just practicing out of session, it doesn't like there's a bit of a gap between us practicing together and then actually facing our kids. So we have to be I think we have to be practical in that part. So what I usually do is I go in the session and then after explaining the instruction part, the modeling should be done with each child, right? So with each child, all the BST parts that we learn for the 6 skills might not go in for that child. It might not apply for that child. So I am the one to find it. I model that part, and then when I see that the child is actually pairing, and then when the therapist can actually see that happening, I then I let the therapist do what I do, imitate what I do. And then through that, I think they can learn a bit more in the real setting. And then so that each child, I can show them. I can show them that I make mistakes. So they might not be like put in the spot. They might see me get embarrassed. They might see me foolish, but they can learn from me, right? So it's like we're the team. We're together in that. So I think that can be a bit of training for them. Yeah.
And the positive reinforcement also, I think it's important.
Mm-hmm.
That does increase their self-esteem. And I get a lot of feedback from the therapists that they want to have more feedback because they're afraid of doing the wrong thing.
Mm-hmm. Mm-hmm.
Yeah. The confidence level when they start is quite low, but then after about a year or 6 months into, they start building up that. But again, it takes um, a lot of effort to give positive reinforcement. We also do videos. We ask the therapist to take videos. And then in our check-ins, then that's something that we discuss. So when in session, when you see a missing link or a weak spot, you can ask them to, in this case, like rapport building, just have them take a 5-minute video of them playing with the kids, and then you can give the feedback that way. It's more consistent than going into sessions, because that takes time and effort also. I mean, in session are valuable. I mean, I like in session, but then you can't do it every time and frequently either. So the videos actually quite help.
I also have a question, since you all have experience with the adults and also for schools or like residential. They're a bit older kids. Like, how do you make, I think, the rapport building, the pairing part with the early learners and the adults and like more grown adolescents might be different. How how are they doing it in schools or residential settings, or like how are you doing with adults? Are there
Depends also.
Hmm?
Go ahead.
It depends, because you also have to look at the adult, because they may be adult, but their cognitive level is still a child. So the things that we present, like this, when we pair, we look at reinforcer assessment, right? So the reinforcer assessment may be babyish thing like Elmo, but it's the way that we respect the person. Like we don't, we can talk about Elmo, we can do like we can play with Elmo, but we don't treat the individual. Like, I think it's more like a respect thing. We don't like, oh, look what we got, oh, look at the Elmo. We don't talk like that, but like, hey, look what I have. I've got Elmo, and look, Elmo, these are cool things that we can do with Elmo. So I think it's the way that we just communicate with them. That's the difference. If you've got like individuals, like adults that are more higher cognitive, I think it's again like discussion, talking about their favorite things, those with good language abilities. The building rapport is more about, like, say, music. I had one adult that loves the Beatles, so we talked about the Beatles. We looked at Beatle videos. We go to Beatle concerts. So it's through conversation. But then I think with the older ones with lower cognitive level, we're going to still be stuck with early learner toys. But again, it's just the way that we don't make sounds. with like elementary, we go like, we imitate choo-choo sounds, or we don't do that with adults, because again, we want to treat them as adults. But jokes are a good breaker. I've got, actually, he turned 20, and he's nonverbal, but he's really an interesting case, because I feel like he has some maturity, but then also I feel like he doesn't. But again, Jion, like you said, imitating their behavior. So he loves to do like, Mama Mia, Tanti. Like, so I do that every time he cracks up. Like if I make if I did something wrong, I'll say, Mama Mia, what did I do? He's partly Italian also. So he gets that, he cracks it out, he cracks up over that. So that's, again, like building that rapport, making little jokes. Like, again, like even though they may not be higher cognitive or high language ability, they can still laugh. There are things that they can laugh about.
Yeah. Sorry, guys. I didn't want to interrupt, but I have another meeting starting. So I have to go. Thank you so much for the great discussion. I really enjoyed it. Thank you,
Good
everyone.
to see you again, Anna.
Okay.
Bye.
Yeah. Tanya, do you have any advice for that?
I think similar to Tanti, depending on their cognitive levels, it's going to be different. So I worked with kids like 20, 22-year-olds, and some kids, not kids, some young adults, we do Play-Doh. So I make shapes for them, but obviously like adult shapes. So like stars, hearts, things like that. We did a lot of jokes. So as you guys know, kids on the spectrum, they have like repetitive vocal behavior, and then they like it when you, like, for example, they have like these vocal stems. So like they say, oh, Sebastian's going to the market, and then where's Sebastian, and then you just have to answer his question, even though it's like he's just repeating it, but it's fun for him. So that's how you build rapport. And then I have some clients where I make my own jokes. So we have our own special jokes. So I'll be like the special person. So it's just I don't think there's like a clear-cut answer, GN, but you can try out different things. I also had success doing like outdoor activities. So like turning on the sprinklers for them, and then going rollerblading with them, swimming, things like that. Yeah.
Yeah, thank you. That's good information. Like I love like the jokes and the things that you can do just specifically with you. But yeah. I asked this question for like how to teach the teachers to actually pair with their clients while they're in a group setting still. So that they feel that very difficult.
That is such a good question, because actually that's what I've been struggling with too, just recently. So I have a client right now. He does great here, but at school, it's like he keeps saying, I hate my teacher. I hate my teacher. And then I told the mom, hey, can we do like a pairing session just with the kid and the teacher? And then like I'll have facilitate. But there's like a lot of pushback from the school. So I'm still trying to figure out how to navigate that. I don't know, Tanti, you have a lot of years under your belt. Please help.
Is it an SSP or is it a mainstream?
It's so with this client, it's really hard because he's high functioning. So the mom did not tell the school that he's on the spectrum. The mom does not want the teacher to know.
Oh,
So
that's hard. Yeah.
it's really hard. I give suggestions, they can't implement.
Yeah, I find there's more resistance with mainstream instead of SSPs. SSPs are more open to like our recommendation, but I think like with mainstream is because I think it's also the ratio of the teacher and then the children. There's one thing like I sat in one of a workshop, like a session. I don't remember what the titles. I didn't jot down notes, but I remember the person saying that in order to teach the teacher to teach the kids, we have to build rapport with the teacher. So yeah, so it's so like with in Australia, because we don't have the luxury of intensive intervention unless they're early. Their model more is working with stakeholders. So my job I build more rapport with stakeholders than with the kids. But when we have that good rapport with the speech, with those, like sometimes we disagree. I disagree with them sometimes behind my, sensory integration, stuff like that. You don't say it. But you have to kind of like but yeah, but I recommend to parents, like, if you want to get an OT, get a one that's functional. Don't get the sensory type, because I need to teach this kid how to pull up her pants, and so I need a functional OT. But yeah, so with so if we have a good relationship with the stakeholders, we can see a lot of decline in the behavior and increase in the in skill building. And they're more willing to implement what we suggest. But it also takes, yeah, and that's the hardest part, is it's exhausting. You know, because it's also listening to them, listening to what their barriers is. So the workshop also said that, like, once we know what the barrier is, we provide that support for them. So sort of like putting ourselves down at their level. Or I don't know, but again, it's like you said, Gio, the whole rapport building. When I saw that, like, oh yeah, it's not just for the kids, it's for the parents, for teachers. But once we have that, like, again, there's more cooperation, like as with the kids, when we have that pairing with the other stakeholders and parents, then we have more cooperation. So I don't know if that's something that, you know, you might want to look back into, Tanya. And and then sometimes also it's good to, like, you know, when we want to give recommendation, we need to also know what their barriers are. Yeah, I have a daycare also that's really, it's just like I haven't had good rapport with them because I only come like fortnightly. And then because I'm trying to get more impact, I send in a therapist, because they can, like, with the X amount of money, they can do 2 hours, versus with me, it's only 1 hour. So I don't have a good rapport with them. And they have misunderstood all my recommendation. But again, I'm trying to think positively, like, oh, okay, they don't understand, and they're telling people that this is what I recommended, which is not what I recommended. It's because, like, during that time, the ratio is not a lot. Loud noises, they have obligations, so I'm teaching them as they go, which is not a good thing. You maybe even talk to like, is it directly with the teacher? Do you have, like, relationship with the principal or anybody above?
So no, this client that I'm struggling with, the mom doesn't want to tell the school that he's in therapy.
So what's the reason? What's your ground?
What?
What's your ground of explaining the behaviors?
I don't know. I'm just like, with this client, I'm just a bit frustrated because the mom keeps bringing up problems at school and she expects me to fix it in therapy. But we all know, like, I can't do that. I have to intervene, like, at school. But she wants to hide me from his school. So I don't know what to tell you, Mrs. XYZ. I can't.
She's expecting that all to generalize at school.
Yes.
Without
just generalizing.
Without any planned generalization. Okay. And the kid doesn't, like, so I think, like, most of with our higher functioning kids, like, when we teach them out, they're very good. They know all the answers, but when it comes to practice,
yes.
Yeah.
The practice part is really hard because, like, theory, they know.
Yeah.
Enforce, like, the correct behavior at the center. Great, nice. Then when they go out, it's like they forgot.
Yeah.
So I don't know.
Yeah. So, like, what we do at our center now, we have, like, afternoon social groups. So we put them in the social groups to practice that. So I mean, like, you might want to also think about, like, having a social, maybe if you know, pull resources, if you can get a social group in place. I think that's your best bet, rather than a one-on-one. I mean, one-on-one is good to teach, but then you need a place where you can practice that, and the school doesn't seem to be an option, so you need to find somewhere else within a social context where you can have the child. I think there may be higher probability of the child actually generalizing from a social to a social context rather from a one-on-one theoretical to a practical.
Yeah.